Thank you so much, and thank you to everyone who's joined us today. I'm excited that we'll be able to spend some time learning how we can all advance our understanding of healthcare delivery using the Compendium of U.S. health systems. We're not using video today, so you'll see on your screen now pictures of all of the speakers. That's me in the top left, and I'm about to turn the microphone over to Mike Furukawa from AHRQ to really get us started. Mike?
Thank you, Jenna. Well, first of all, welcome to everyone. I hope you are safe and well wherever you are. We're very excited today to share information about the AHRQ Compendium of U.S. health systems. This is a 5-year project, and we've put a lot of effort into developing these resources, so we're excited to share that information with you. We encourage you to ask questions and provide feedback on the compendium, both during the webinar and afterwards, so feel free to contact us if you have any follow-up questions. Now I'd like to turn it over to Gene Rich.
Thanks, Mike, and thanks to you and to AHRQ for the substantial investment in understanding health systems in the United States through the Comparative Health System Performance Initiative. I'm here to give a little bit of an intro before we get into the real meat of our discussion. I will be providing an overview of AHRQ's Comparative Health System Performance Initiative. Then I'll turn the microphone over to my colleague, Dave Jones, who will describe the Compendium of U.S. health systems. Then my colleagues, Rachel Makta and Danielle Witcher, will discuss a couple of examples of how researchers can use the compendium to analyze health systems. Following each of their presentations, there'll be a brief time for answering some initial technical questions, and then we will have a more substantive question and answer discussion responding to questions posed by folks in the audience. The AHRQ Comparative Health System Performance Initiative had the goal of understanding the factors that affect health systems' use of patient-centered outcomes research and to identify best practices in disseminating and using that information. The initiative had several components. There were 3 centers of excellence that were groups of researchers supported through AHRQ cooperative agreements. These researchers were really drawn from researchers on health systems across the United States, but the centers were located at Dartmouth, the National Bureau of Economic Research, and RAND. And then there was an additional investment in a coordinating center for the Comparative Health System Performance Initiative, and that was with our Mathematica team. So at the coordinating center, I'm the project director, and the deputy project directors for our work on the Comparative Health System Performance Initiative were Dave Jones and Jenna Cohen. The coordinating center collaborated with AHRQ to convene stakeholders and technical experts, to facilitate collaboration across the 3 centers of excellence, to support synthesis of research findings and to analyze data, to promote dissemination of research on health systems like the webinar today, and most substantively to develop a compendium on health systems that includes various kinds of information on system characteristics. And now I'll turn the discussion over to Dave Jones, who's going to describe the Compendium of U.S. health systems. Dave.
Thank you, Gene, and thank you everyone for joining us today. Before we launch in, I'll go over a bit of a roadmap for this section of the presentation. We'll begin with an overview of the compendium, and that is what I'll be spending most of my time during the webinar today going through. There are 3 components or files that comprise the compendium or compose the compendium. The first being a compendium list of health systems, so a health system level file. The second, a linkage file at the hospital level that links back to the health system level file. And then also a group practice linkage file at the group practice level that links back to the health system. After that portion of my part of the webinar, I will talk a little bit about how you all might find the compendium useful in examining health systems, and also talk about how we've been using the compendium to do the same. So we'll put it all together, meaning all 3 of those files listed above, I'll run through some of the system characteristics that are included in the compendium that you all might be interested in, and I will also talk about linking the data to some external data sources to expand the possibilities with these data. So before we jump into really the meat of the content of this section, I did want to say a few words about why we are particularly excited about the prospect of sharing these data publicly with you all and the larger sort of community of folks out there that are interested in studying health systems, and why we think these files really expand the possibilities for studying healthcare delivery in the U.S. So a bit about motivation. So consolidation is a fact of life for healthcare delivery in the U.S. Health systems now touch all aspects of care for many patients, for many of us, and for those of us that it doesn't touch every aspect of care, it touches a pretty substantial portion of the care that we receive in the U.S. in many locations. So consolidation could have quite a large effect on the cost and quality of care, and indeed there has been a growing body of literature developing on this topic. A lot of really high quality studies have addressed this very issue. Many of those actually are part of and funded under the CHSP initiative. But I would argue that there's certainly still a lot of room for understanding of health systems. And I would also argue, at least before the CHSP initiative, that we were largely held back by limited data on health systems. So there's no agreed upon definition of a health system and no agreed upon way of identifying health systems. So in comes the CHSP initiative, and AHRQ's Compendium of U.S. Health Systems is the first publicly available database of health systems and linkages to system hospitals and group practices, which, as I mentioned a minute ago, really does open up many opportunities to examine how health systems operate to deliver care. So that's a bit on the motivation. The first of the three files that I'll be discussing that compose the compendium is the list of health systems. So before we created a database of health systems, we had to identify them. So the first step in that process was to convene a work group with the Centers of Excellence that Jean mentioned a few slides ago, back in 2016. And it's quite a difficult task to define health systems, as I'm sure you can imagine. If we all wrote down our definition, we probably would have a definition for every person that's joining today. So we started with a simple and relatively unambiguous, albeit narrow, working definition of a health system that could be brought into operation with available data, and that last part is key. So what we came up with is, and I'll just read what's in quotes, a health system includes at least one hospital and at least one group of physicians that provide comprehensive care, including primary and specialty care, and are connected with each other and with the hospital through common ownership or joint management. Now, as I was alluding to earlier, we could certainly debate this for hours, and we have. I want to acknowledge that there are entities or arrangements that you all might be thinking about that are not sort of included in this definition, and that's a fair critique. But again, we needed to start with a simple definition that covered, and I would argue that it really does cover a lot of what we all think of as health systems in the U.S., and it can be operationalized with data. So that brings me to my next slide, which shows how we did that. And this is another topic that we certainly could debate for hours, and we have, and we could have a whole webinar about how we did this. But we used the definition of a health system, using the definition of a health system, we required that organizations or entities that were up for consideration for being included in the compendium must have at least one non-federal general acute care hospital. So that's largely right there in that working definition on the previous slide. And then it gets a little bit more complicated. So we required 50 total physicians and at least 10 primary care physicians. We searched the literature. We had many discussions internally and externally with experts. We looked at the literature on what is a reasonable sort of configuration and number of physicians to meet that working definition. And we considered other combinations of certain specialties to meet the working definition. But this is where we landed, and getting back to it needing to be able to be operationalized in the data and be fairly straightforward and meet that definition of vertical integration that we were looking for. We also conducted some sensitivity tests. So we looked at those entities that were just above and below the cutoffs. And for those that were below, so they didn't quite make the compendium, we didn't find any entities that were obviously meeting the working definitions that we should have included. And then on the other side of the cutoffs, we didn't find any that we did include that clearly did not meet that working definition. So happy to talk more about this in the Q&A section, but this is in short where we landed. So the compendium list of health systems, where did we land? What does it look like now and what's publicly available? So it lists health systems operating in 2016 and 2018 that meet that working definition. So when I say 16 and 18, there's a 16 file and then there's an updated 2018 file that you can download separately. The data sources were the IQVIA 1-key and the AHA annual survey data. And I'll just make a note here that for those that are familiar with the data, in 2016, IQVIA maintained separate databases called HCOS and the SKNA data. And then in 2018, they combined those data sets. So when you're looking at the 2016 technical documentation on the AHRQ website, you'll see it referred to as HCOS and SKNA. Just know that we're talking about the same thing in 2018. It was combined. And we found 626 systems meeting that working definition in 2016. And then in 2018, we found 637 systems. And this is a link that we can put in the Q&A for you to go to the AHRQ webpage, to the compendium page, so you can download the data. And speaking of downloading the data, if you go to that website, that web page, here's what you'll find. So this is just a screen capture of the landing page. When you first get there, it will give you an option to go to the 2016 data or the 2018 data. So if you click 18, this is what you'll find. And then if you scroll down just a little bit from there, this is what you'll see, and here's where you can actually download the files. That first link there is if you want to just download all of the files at once in a zipped file, you can do that. But what I really want to focus on are those next two. So there's a CSV version and an Excel version of the database. I'll just note below there, you'll see that there are links for the technical documentation that goes through how we created the data, what is included in the data, and so on in great detail. So those are great resources. But if you focus back on the middle of the page where we have the CSV and Excel file, there's the same information. If you just click on one of those, here is what you will see. So this is a screen capture of the compendium, of the list of health systems. So each row is a health system. It is purposefully very simple. It is intended for you all to be able to use it, to download it, understand it, and link it to other data. So just running through this very quickly, and again, this is just a screen capture of just the first 20-ish rows. There are 636 systems in the data. The first column is a health system ID that we assigned, so it's unique so that we're able to track systems over time from 16 to 18 in this case. And also, as you'll see later, be able to link the different data files that compose the compendium. And then we just have some basic information, name, city, state, come directly from the data. That would be the headquarter location. There are flags in columns E and F that tell you whether it's in the 1-key data or the AHA data or both, and then the IDs for those data. So if you have those data sources, you can link the compendium directly to them and then just expand on the possibilities of what you can do with the data. There are many other columns in the data that aren't being shown here, and I'll get into those later. Those are a number of characteristics on health systems. But this is just to give you a sense of what the data look like. So if you download it, this is what you'll be seeing. So that's the first file. The second file is the hospital linkage file. It's at the hospital level. And the hospital linkage file lists all hospitals in the US in 2016. And then there's a 2018 version of the file. And it links those hospitals and systems to the compendium list of health systems. So I want to note here that the file includes not just hospitals that are in systems, but also those that are not in systems. So it's all hospitals that are in the data. And it links to the list of systems using a unique compendium ID, which I showed on the previous slide, but I'll also show again in a few slides so you can see that again. And it also includes the CCN, which I'm sure most of you are familiar with, to link to external data sources. So again, that really opens up the range of possibilities of how you can use the data. The data sources are, again, IQVIA and the AHA data. IQVIA and AHA directly link hospitals to health systems in their data. So for us, we're largely taking that information and just joining it and reconciling any differences between the 1-key data and the AHA data. And what we found was we ended up linking 70% of hospitals in systems in 2016, and we found that there were 72% in 2018. So a fairly large percentage in both years, and at the hospital level, just a slight increase from 16 to 18. We'll go over later what that looks like for physicians and physician practices. So if you go back to the Compendium website, on AHRQ's website, this is what it will look like. This is the page for the hospital linkage file. It looks very similar to the section of the page for the Compendium list of health systems. You can see in the middle an Excel and CSV version, and then the technical documentation. So if you go to the page and you click on the link in the middle there, here is what the hospital linkage file looks like. So again, we were really aiming for simplicity so that you are able to understand it and link the files. In column A is a unique ID that we created, again, to be able to link the files across years. But of course, for hospitals, we have the CCN, which is column B. Then we have information in columns, let's see, C through G directly from the data, so the hospital name and its location. And then in columns I through J, that's where you have the linkage information back to the list of systems. So that's column I is the unique health system ID. If it's populated, that means that the hospital is in a system. If it's not in a system. And then column J includes the health system name. So that's the second file. And then the third and final piece of the puzzle of the compendium is the group practice linkage file. So the group practice linkage file lists group practices, and when I say group practices, I mean TINs, so tax identification numbers, in 2016 and 2018. And like the hospital linkage file, it links those that are in systems to the compendium list of health systems. Those that are not are still in there, just like hospitals. They just don't have health system information. Now, TIN as group practice is another one of these issues that we certainly could discuss in much more detail. We follow CMS's lead in the treatment of TINs as group practices. We've had a lot of discussion about what it means to do that, what's the overlap between TINs and group practices as most of us think of group practices, and happy to answer questions about that in the Q&A, but just want to make it clear that when I say group practices, the way that we're identifying them is TINs in the data. So the group practice linkage file includes all group practices with more than one physician billing Medicare. So in the public version of the data, we do not include solo practice TINs for confidentiality reasons. The data link the list of systems using a unique compendium ID, which is analogous to what we did with the hospital file, and I'll show you what that looks like in a moment. And it also includes information to link to external data sources, which we'll focus on in the latter portion of this presentation. We did use Medicare data on physician practice and specialty, what we refer to as MD-Pass, to identify the set of group practices and physicians to be considered for linkages. So if you want to think about our starting point and the universe of group practices and physicians, that's our starting point. And then we combine the information on possible linkages from a host of data sources to identify the final linkages for each group practice and their physicians with systems. So this, again, is another point where we could spend hours discussing this, and I'm happy to answer questions. There is no data source, unfortunately, that links group practices to health systems. So that was a big part of what we did and what we're adding here in terms of publicly available information. So the way that we did it was we combined from a number of different sources bits and pieces of evidence that would suggest that a group practice and its physicians are in health systems. We combined all of that information to give us a final assessment of whether it's in a health system or not, and that's what we went with for the group practice linkage file. To give you just a bit of a sense of the percentage of group practices and physicians that are in systems, let's just start with the first two rows of the table in white. So the first one being group practices. In 2016, there were roughly 41,000 group practices in the U.S., and these are excluding the single physician group practices. And then in 2018, the number actually declined to 39,000. If you look at what happened to physicians, the physician numbers went up. So fewer group practices, more physicians. So from 556,000 to over 585,000. So if you look at the percentages, you see that those went up. And so the group practices, the percentage of group practices and physicians went from 13% to 15.7%. pardon me. And then for physicians, the percentage went from just under 52% to over 56% in 2018. Pardon me. So you might be wondering, well, okay, that's not all physicians. What would happen if we looked at all physicians that are billing Medicare? So that includes single physician practices. So pardon me, this is not part of what's publicly available, but if you assume that all of those single physician practices are not in systems, and we understand that certainly that won't be completely true, that there are surely some that are in systems, but from what we've seen in our work, it's a fairly safe assumption that the vast majority of those are single physician practices are not in health systems. Pardon me for 1 second, I need to clear my throat. Thank you, I'm back. So if we make that assumption, this is what we see in the final 2 rows of the table. So just focusing on the physician row, you see that the numbers there, 644,000 in 2016, over 660,000 in 2018, and the percentage that are in systems changes from just under 45% in 2016 to almost 50% in 2018. So what does the file look like? So if you go to the Compendium webpage, it looks pretty similar to what we showed for the hospital linkage file and the system level data. There's an Excel version and a CSV version. This file, given that there are just many more group practices in the country, is going to be quite a bit larger. And then there's a link below to the technical documentation. Again, I would direct you there if you have any questions. There's a wealth of very detailed information about how we created the data and the contents. And then if you click on it, this is what it looks like. It's fairly straightforward. This is opening it in Excel and taking a snapshot of the first 20-ish rows. So each row is a group practice or a TIN. You can see there in column A, we have the TIN name. We then have an identifier that is almost completely one-to-one with TIN, and it is publicly available. That's why we can report it, which is the PACOS PAC ID. And then we have the health system ID and health system name. So this is the column C and D is where you would identify whether the group practice is in a system or not. If the information is missing, then it's not in the system. If it is there, then that indicates that that group practice is in a system. All right. So those are the 3 files that compose the compendium of U.S. health systems in 2016 and 2018. I did want to talk a little bit about how you might use the compendium, and then I will also tee up the next 2 sections of the webinar, in which my colleagues Rachel and Danielle will talk about some specific work that we've done. But just first, putting it all together, these are the 3 files. So what I did was, and I imagine that most of you will download the files, read them into either Excel or SAS Data R, your favorite software package, and link them all together to look at the nation or a state or a region. But just to give you a sense of a different way of looking at this and how to combine the files and how the information links up across the 3 files, I just took alphabetically the first health system in the files, and it's Adena Health System, which is in Ohio. So you can see there the health system ID. You can see in the second sort of snapshot there, or screenshot, that's from the hospital linkage file. And if you look for that health system ID in the hospital linkage file, you will find that we identified 3 hospitals, and those are the rows listed in the middle of this slide as being in the Adena Health System. And then if you go the step further down to the group practice linkage file, still using that health system ID, if you look for the group practices with that health system ID, you'll find that we've identified 3 group practices or 3 TINs that are in Adena Health System. So they're right there. And you can have all of the information. It's cut off to the right, but there's plenty of extra information about the number of physicians in the group practice, information on hospitals, information on Adena Health System. So that's just to give you a sense of the relationship between the 3 files. System characteristics that are included in the compendium, this is where I alluded to earlier that in the compendium file, there's a lot more information over to the right that's just not shown on the screen. If you download the file, you'll find this wealth of information. So just to give you a sense of what's there, first, counts of providers, physicians, total and primary care, count of groups, advanced practice clinicians, and then counts of hospitals, beds, discharges, and nursing homes. Then there's another set of variables that indicate the type of system, the range of the system, et cetera. So the geographic scope, the ownership type, the teaching intensity of the hospitals in the system, the extent to which the system hospitals are safety net hospitals, whether the system providers are participating in alternative payment models, and finally, whether the system offers a health plan. So a wealth of information that you can use to look into health systems. Linking to external data sources, I mentioned earlier the CCN in the hospital linkage file. So you can link it if you have access to the AHA annual survey database. The provider of services data has a wealth of information on hospitals. It's publicly available on CMS's website. Hospital cost reports data also publicly available from CMS. And your favorite data source, if it has CCN or some other way to link to hospitals, you can link the compendium to it. With the group practice and physician linkages, we do have TIN name in the file, so you could do kind of a fuzzy match to IRS 990 data to MD Pass. You can use the PAC ID, which I mentioned earlier, which comes from PACOS, so you can link directly to the PACOS data, which I'm happy to say more about, but essentially think of that as the CMS's enrollment system for Medicare providers, and then also Physician Compare, which is available publicly on the web. But we also, I just want to mention, we include the information needed to uniquely identify TINs between the group practice linkage file and the MD Pass data. So if you have access to MD Pass, you can uniquely link the data in the group practice linkage file to those. The MD Pass data then includes the information on the physicians that are in those group practices, and then that just opens up a whole other world of information that you could then link to the data, including claims and so on. I want to speed through the next couple of slides because I realize that I'm running out of time. The resources that are available, I've already mentioned the technical documentation. I do encourage you to go there. Some of the analyses that we've already conducted using the compendium can be quite helpful. The first few, these are all published papers. The first few look at the landscape of health systems in 16 to 18. The next few look at starting to break down consolidation by physician specialty, looking at APM participation, so CJR there, looking at academic affiliated health systems, and then also starting to look at within health systems nationally, look at how they operate in markets. Just two more slides and more examples of how we've used the data, and I think this is largely just teeing up the next section. If you go to the compendium website, you'll see a list of what we call data briefs that have information. These are just graphics pasted in from those. I don't expect you to be able to read this, but they focus on topics such as types of systems, consolidation of physicians, geographic variation, and then APM participation or ACO participation in the case of the lower left. And then one final slide, which is one that I just really like. You can do, this is a graphic that we created solely using what's publicly available, and it really drives home just one of the takeaways, I think, from the past, one of many takeaways from the past 5 years, which is that this is a bubble chart showing a bubble for every system, and the groups are by ownership type, so nonprofit, public, investor, and then church operated. And then you can see the size of the bubbles are the size of the system by number of hospital beds. So the takeaway, and this is just one example of many, is that there are many nonprofits that are smaller on average, similar for public and government, although a smaller number, and then a really small number, but very large set of investor-owned systems, and then similarly for church-operated. So just show this as kind of a cool graphic that we created solely using the publicly available data, and I think that transitions us into more specific presentations by my colleagues. But before I turn it over, Shanna, do we have a minute or two for a technical question, or should we move on?
We have a minute or two, and we have a couple questions that have come in, and any that we don't get to, we will try and follow up with folks after today's webinar. So the first question is how you would know if two or more systems have merged, possibly even under a whole new name.
Yes, that is a great question, and we certainly have seen that, and we have seen quite a bit of that just over the 2 years from 2016 to 18. So we see that, we observe it in the data, and then we represent that in what's the publicly available files. The way that you would do that if two systems merge into a whole new system, just looking at the list of systems, you wouldn't know it because they would have a new ID. One way that you would is, we might have this in the technical documentation, but I know we have it in, and I'll just go back a few slides, in the health affairs paper in 2019, but on system consolidation in 2018. I know that we have a list of the mergers and acquisitions that happened from 16 to 18. So I think that's probably the easiest way for you to see it. You could also look at the hospital linkage file to see where the hospitals are going. So if they're under one system in 1 year and then all of the hospitals under two systems are now under a different system, that's one indirect way of seeing it. But I think the best, most direct way is to look at this paper in 2018, because I'm fairly certain that we actually created a crosswalk of what happened between 16 and 18 in terms of mergers and acquisitions.
Great. Okay, and I think we only have time for one more question, which is unfortunate because there are several great ones. So quickly, we have one question that would like to confirm if the files can be linked to individual physicians.
They can, and that's what is behind the publicly available data. For you to do that, you would have to have a crosswalk, some way of getting from group practice to physicians. So if you have access to claims data, if you have access to MD-Pass, I think ideally would be the best way to do that. But certainly, yeah, based on the group practice data, if you have data that links physicians to group practices, you can link physicians then to the systems.
Great.
And there are other ways of doing it, so using PAC ID and so on.
I think we can squeeze in one more question, which is that given our use of Medicare data, can you comment on the inclusion of pediatric-focused providers in the compendium?
It's a great question. So if you're looking at, you can use those group practices to include physicians that are not billing Medicare, but the group practice linkage file is built off of Medicare data. And so it's going to exclude some practices that are solely focused on pediatrics. Does anyone else on the team have thoughts on this topic in terms of what's feasible?
Yeah, hey Dave, this is Mike. I'm sorry, go ahead, Gene.
Go ahead, Mike.
Well, there's an indicator for...
We're lagging. Go ahead. Go ahead.
There's
Mike.
an indicator for whether the system is predominantly children's based on the children's hospitals. So that's one way you could look at, you could see whether the system is predominantly children's hospitals and then look at the TINs or group practices affiliated with that system.
I'll also add, it is correct that because the group practice linkage file is Medicare data, we know that that only a minority of pediatricians bill the Medicare program and will show up. But if you have access to the IQVIA OneKey data and have access to their physicians, you could, because we provide the buyers, you could link the physicians into the compendium yourself. And that would include all the physicians that IQVIA has tracked.
Well, this has been fascinating. Thank you, Dave, Gene, and Mike, but I don't want to keep people waiting one more minute before we learn about advanced practice clinicians and practice settings affiliated with health systems. Rachel?
Okay, thanks, Jenna, and thanks, Dave. That was a really great overview of the compendium. So I want to switch gears a little bit and share some information on advanced practice clinicians and practice settings affiliated with health systems. And these findings are meant to describe both what we know about APCs and systems and also to illustrate one way in which the compendium can be used to support health services research. So before diving in, I'd like to acknowledge my colleagues who have worked with me on this study, including those at Mathematica, Dave Jones and Gene Rich, and several at AHRQ, including Mike Furukawa, Arlene Behrman, Bob McNillis, and Tim Lujan. Okay, So motivating this research is two really important underlying trends, one of which we've talked about already a fair amount today. And so really first is a growing number of advanced practice clinicians that are operating as key members of our healthcare workforce. And concurrent with that trend is the trend that we've been discussing for the first half of this presentation so far, which is the rapid consolidation of physician practices in hospitals into vertically integrated health systems. And really, both of these trends have important implications for the cost and quality of care. And, you know, a fair amount has been written on both of these topics separately, but relatively little is known about how the two trends intersect. And so that's where we're starting to try to fill the gap with this analysis. So in this study, we sought to quantify the employment of NPs and PAs with health systems. And we wanted to really examine the variation of employment of NPs and PAs in health systems by practice setting, practice type, state, and scope of practice environment. So what I'm going to present today, particularly due to time constraints, is really just a descriptive analysis that I hope sets the stage for some future research that can begin to connect these findings with some really important policy important outcomes. Okay. So this study leveraged data from IQVIA's 2018 One Key database, and we used that data to identify NPs and PAs that are practicing in the US in 2018 and their practice setting and system affiliations. We then linked these providers to the 2018 AHRQ Compendium of US Health Systems using a unique organization ID that's going to be common to both data sources. And then finally, we used data from the American Association of Nurse Practitioners for NP scope of practice environment and a recent article by Valentin et al. For physician assistant scope of practice environment. And that allows us to categorize states based on their scope of practice laws. Okay. So in the next few slides, I'm going to share kind of a lot of results that look at the extent of employment of NPs and PAs in health systems. So I wanted to first take a moment to orient you to how these results are going to be organized. So basically, we're going to drill down 3 levels. So first, we're going to look at the practice setting level, again, examining the extent of NP and PA employment by health systems, by medical practice sites, hospitals, and long-term care facilities. And then we're going to drill down among medical practice sites to look at the medical practice site type, and that's going to be defined by the specialty of the physician in the site. So that would mean looking at the extent of NP and PA employment in single specialty practices, multi-specialty practices, and primary care practices. And then finally, we're going to drill down one more level to look at the employment of NPs and PAs in systems in single specialty practices by specialty. So those will include specialties like cardiology, orthopedic surgery, and hem-onc single specialty practices, among others. So this is not the complete universe of practice settings or practice site types or specialties. These are just meant to be exemplary of the type that we looked at. Okay, so with that overview in mind, let's get into the results. So as you may know, there are more than twice as many NPs as PAs practicing in the US, about 260,000 NPs versus about 120,000 PAs. They generally practice in similar practice settings, most commonly working in medical practice sites, about 60%, with fewer working in hospitals, just under 15%. A fairly small number, less than 1%, are working in long-term care facilities. The remaining quarter about of APCs are practicing in other categories, which include ambulatory surgery centers, home health agencies, and imaging centers, among other facility types. Okay, so next we're going to look at these practice settings. Among these practice settings, what percentage of NPs and NPAs are employed in health systems? Excuse me. So overall, just over 40% of NPs and close to 45% of PAs were employed in practice settings affiliated with systems in 2018. And I just want to point out here that these figures are fairly similar, but a little bit lower than the percentage of physicians affiliated with systems in 2018, which was about 51%. As you can see in this slide, the percentage of NPs and PAs in systems really varied substantially by practice setting. So among NPs and PAs employed by medical practice sites, which again is the most common practice setting for NPs and PAs, just under 40% were affiliated with systems. And we can contrast that with hospitals. So system affiliation is much more common for NPs and PAs employed by hospitals. Among NPs and PAs employed by hospitals, roughly 75% and 80% were affiliated with systems, respectively. I'll note here that this is kind of generally consistent with the higher percentage of hospitals in systems that Dave mentioned earlier. So about 72% of hospitals were in systems in 2018. And if we look among hospital beds, that number is even higher, about 91% of hospital beds. We also see here that relatively few NPs and PAs were employed by long-term care facilities. And among those, relatively few were in systems, so about 13%. Okay, so in the next slide, we're going to drill down a level to examine the extent of NP and PA employment by systems among different medical practice site types. So just digging into this medical practice site category. So first, as context, here we are defining practice site types based on the specialties of the physician in the practice. So 41% of NPs and 36% of PAs are in primary care practice sites. And by primary care practices, I mean those in which the majority of the practice's physicians have a primary care specialty. Roughly another third, about 31% of NPs and 37% of PAs, are in single specialty practices, again, meaning those in which the majority of the practice's physicians are in a single specialty. And then approximately 15% are in multi-specialty practices, defined as those with where no specialty would compose the majority of the practice's physicians. The other group here refers to NPs and PAs that are either practicing in multiple practice types or in a practice with no physicians. Okay, so now looking at the results here, among NPs and PAs employed in medical practice sites, system affiliation is more common for those in multi-specialty practices, so that's roughly 50%, compared to those in single specialty practices, that would be about just under 40%, and those in primary care practices, which would be the lowest of these three groups, which is roughly 35%. So some interesting variation here. Okay, and finally, we're going to look at what specialties are represented among single specialty practices. So a greater percentage of NPs are employed by OB-GYN, psychiatry, cardiology, and HEMONC single specialty medical practices. This is where we see a little bit of a difference across NPs and PAs. So a greater percentage of PAs are employed by orthopedic surgery, dermatology, and emergency medicine single specialty medical practice sites. So as before, we're going to kind of dive down and look at, by these specialties, what percentage of APCs in each of these practice types are employed by systems. Okay, so as you can see here, there is quite a bit of variation of the percentage of NPs and PAs employed in health systems by specialty setting. So NPs and PAs employed by cardiology, general surgery, and HEMONC are the most likely to be affiliated with systems, while psychiatry, dermatology are the least likely. And I'll point out again here that these findings are largely consistent with the findings in a recent HSR paper that Dave mentioned earlier that we looked at that examined variation in physician specialties associated with systems. So that paper, we also found cardiology, general surgery, HEMONC having the highest affiliations with systems, and psychiatry and dermatology having among the lowest. Okay, so I'm going to take a step back again and give you a brief results roadmap here before diving into some additional results. So in the next couple of slides, we're going to look at the percentage of APCs employed in systems and how that varies by state. And then we're going to drill down once again, looking at states by their scope of practice environment. And we're going to categorize states as having either full, reduced, or restricted scope of practice environments. Okay, so here we have two maps. And these maps are looking at the percentage of NPs and PAs employed in health systems by state, where the darker color represents a greater share of NPs and PAs employed by systems, and the lighter color is obviously a lower percentage. And we find that there's really substantial variation in the percentage of NPs and PAs employed by systems by state, ranging from about 9% of PAs and 3% of PAs, 9% of NPs and 3% of PAs in systems in Alaska, to 63% of NPs and 68% of PAs in systems in Wisconsin. So in general, we find that the percentages are highest in the upper Midwest and Northeast, which is consistent with the general pattern observed for consolidation of physicians in hospitals and systems. Okay, so here we're looking at the number of NPs and PAs per 10K population, as well as the share of NPs and PAs in systems by scope of practice environment. As expected in this kind of first column on the left for both NPs and PAs, we see that there are more NPs and PAs per capita in states with less restrictive scope of practice environment. So then if we move to the column to the right, the percent in systems, kind of interestingly, we see no clear relationship between scope of practice environment and the share of NPs and PAs in systems, which is to say that system affiliation neither consistently increases nor decreases with more or less restrictive data.
Rachel's audio. I'm not sure she's aware of that right now. The discussion while we're waiting for Rachel to rejoin.
Gene, I can jump in and give the discussion. Would that be helpful?
That'd be great. Thanks. Apologies all for the technical difficulties.
Sure. So just putting together essentially all of the results that Rachel just presented, we do find that a substantial share of nurse practitioners and physician assistants were employed in practice settings affiliated with systems, so it's over 40%, which is comparable but somewhat less than the 50% that we see for physicians in other studies. They do generally mirror the trends in consolidation. So nurse practitioners and physician assistants employed in hospitals much more likely to be in systems than those in medical practice sites, long-term care, and other facilities, which, as we've said, mirrors the very large percentage of hospitals and hospital beds that are in systems. Nurse practitioners, physician assistants employed by certain specialty types, cardiology, hem-onc, and general surgery, the most likely to be affiliated with systems. Psychiatry and dermatology are the least likely, which is consistent with a recent HSR paper that looked at physician consolidation by specialty. Moving on, it does vary by system characteristics, the number of nurse practitioners and physician assistants. So we did find that, and this is a piece that Rachel didn't present in the main body of the presentation, but systems that are in multiple states that offer a health plan and participate in APNs have more nurse practitioners and physician assistants on average, and that's after we control for the system size and the other system characteristics. As Rachel mentioned, we don't see a clear relationship between nurse practitioners and physician assistants in systems and the scope of practice environment or the restrictiveness of the state laws. And then wrapping up, future considerations. So given these concurrent, very important trends in healthcare delivery, policies aimed at the delivery of care by advanced practice clinicians should consider that there are a substantial percentage of nurse practitioners and physician assistants that are operating under systems, particularly as we've seen in the hospital setting. And as Rachel started out by saying, more work is needed to understand the potential effects of this consolidation on cost and quality of care to inform these policies, and there are potential fairly substantial implications here for cost and quality of care.
Thanks, Steve, for picking it back up. Having a COVID
Welcome back.
Here where,
no problem.
Your audio fails you, but thanks so much.
Sure.
Jenna, do we have any clarifying questions, and do we have time to answer a few of those?
One, and Rachel, because I know you just rejoined, there were one very good question: do you account for nurse-led clinics that have no physicians? And Rachel, if you could navigate back to 41, I'll just mention that, and you can take it from there. The gray wedge reflects a diversity of, or pardon me, the orange wedge reflects a diversity of other practice settings, and I believe, Rachel, those include practice locations that IQVIA identified as having no physicians.
That's right. So we have a small number. The other groups that we didn't present today, but will be included in a future paper, hopefully, are multiple practice types. So some NPs and PAs are practicing in multiple practice types, and some are a fairly small number, but some are practicing in a practice type with no physicians. So those will be included in a future analysis. But yeah, we didn't dive into that today.
And just one other note on that, that is the group that has the lowest sort of participation rate. That's not the right term, but the percentage of NPs in systems, that's the group that has the lowest percentage among all of the practice types.
That's right. So I think that's about 20% of them are in systems compared to the 30 to almost 50% among these other groups.
Great, thank you so much. I'm going to go ahead and move these slides forward and turn the mic over to Danielle, who's going to share what we've learned about health system and physician participation in Medicare APM.
Thanks, Jenna, and good afternoon, everyone. As Jenna mentioned, today I'm going to be talking about our use of the 2018 Compendium of U.S. Health Systems to look at health system and physician participation in Medicare alternative payment models during 2018. I'd also like to acknowledge others who contributed to this work, including Rachel, Dave, Jean, and Mike, who you've already heard from during this webinar today. In terms of a roadmap, I'm going to start this presentation by providing some background on what alternative payment models are and why it's important to look at who's participating in these models. I'll then describe our methods for looking at which physicians and systems are participating in these models, as well as our results. And I'll end by discussing some policy implications from this work. So starting with some background on alternative payment models. CMS, or the Centers for Medicare and Medicaid Services, define APMs as payment approaches that give added incentive payments to provide high quality and cost-efficient care. The reason why it's important to understand which health systems and physicians are participating in Medicare APMs are that most healthcare services are reimbursed by health insurers on a fee-for-service basis. This incentivizes healthcare providers to provide more services and not necessarily high-value services. Healthcare spending accounted for about 18% of the U.S. gross domestic product in 2019 and is higher than other OECD countries, yet U.S. health outcomes are worse in many cases, so there's a push to understand how we can finance healthcare in a way that rewards value and leads to improved outcomes. In 2019, the Affordable Care Act created the Center for Medicare and Medicaid Innovation to develop and test alternative payment and delivery models, and since then, the Innovation Center has implemented a number of different types of APMs. However, in order for these models to be successful at curbing rising healthcare costs and improving quality, there needs to be widespread participation by physicians, practices, and health systems. There are three main types of alternative payment models that the Innovation Center has implemented and that influence payments to physicians, and those are accountable care organizations, which are doctors, groups of doctors, hospitals, and other healthcare providers who come together voluntarily to give coordinated, high-quality care to their Medicare patients. Episode-based payment models that set a single spending target for all applicable healthcare services provided during a clinical episode of care over a specified period of time. And primary care transformation models, which incentivize primary care practices to use health information technology and data to transform their delivery of care while being accountable for the cost and quality of care their patients receive. So again, our objective was to present new data on the percentage of health systems and physicians in 2018 that participated in different types of Medicare APMs. So I'll now walk through our methods for looking at this. To understand which physicians and health systems were participating in Medicare APMs, we used CMS's APM Management System database from 2018. And this database has data on all providers by their national provider identifiers and practices through their TINs participating in Medicare APMs, as well as the specific APMs they are participating in. We limited this database to a set of APMs that are national in scope and that influence payments to providers, and I'm going to show you what those APMs are on the next slide. And then we linked that data to the 2018 group practice linkage file that Dave talked about to determine which systems had affiliated physicians participating in Medicare APMs. So again, these are the specific Medicare APMs we looked at. These are APMs that were active in 2018, that were national in scope, meaning they weren't limited to a specific state, and that influenced, again, payments to physicians and practices. So specifically, we looked at 3 ACO models. That includes the Medicare Shared Savings Program, the Comprehensive End-Stage Renal Disease Care Model, and the Next Generation ACO model. We also looked at 3 episode-based payment models, including the Bundle Payments for Care Improvement Initiative, the Comprehensive Care for Joint Replacement model, and the Oncology Care model. And we looked at 1 primary care transformation model, and that's the Comprehensive Primary Care Plus model. Now I'll present the results we found overall and by Medicare APM type. Overall, we found that about 45% of physicians billing the Medicare program were participating in Medicare APMs during 2018. We also found that a greater percentage of physicians that were affiliated with health systems were participating in Medicare APMs compared to physicians who were not affiliated with health systems. So you see in the middle, that bar represents about 56% of system-affiliated physicians billing the Medicare program, and the bar on the right represents about 33% of non-system affiliated physicians. This slide shows that physician participation in Medicare APMs was driven by participation in ACO models. You see a much bigger number in the top row compared to the bottom 2 rows. So you also see that a relatively small number of U.S. physicians billing Medicare were participating in Medicare episode-based payment models or the primary care transformation model. This is in part because only certain types of physicians and practices were eligible for these Medicare APMs. So just to give you an example, Medicare's oncology care model is targeted at physicians who treat beneficiaries with cancer. And the Comprehensive Primary Care Plus model, which is the primary care transformation model, is targeted at primary care practices. The one other thing I want to mention is that one of the episode-based payment models, Comprehensive Care for Joint Replacement, and the only primary care transformation model, which again is CPC Plus, were only available in specific regions across the United States, so not all physicians were eligible to participate in those models. This slide shows that among health systems participating in Medicare APMs, a median of 80% of health system physicians were engaged in that APM. Again, this finding was driven by systems participating in ACOs, where you see a median of 85% of physicians were participating. And this likely reflects ACO's emphasis on total cost of care, as well as the inclusion of different types of specialists in ACOs. However, I want to also point out that across systems, the share of participating physicians in ACOs varied from 56% for systems in the 25th percentile to 94% for systems in the 75th percentile. And then finally, consistent with the narrower focus of episode-based payment models and primary care transformation models, these models had a smaller percent of physicians participating among those that were affiliated with systems in these models. So for primary care transformation models, you see a median of 10% of physicians participating. And for episode-based payment models, you see a median of 4%. This slide takes the system perspective and shows that overall 68% of U.S. health systems operating 2018 were participating in Medicare APMs, with 58% participating in ACOs, 68% in episode-based payment models, and 19% in the primary care transformation model. I also want to point out that of the 58% of physicians that were participating in Medicare ACOs, 38% only participated in an ACO, while another 20% also participated in either the primary care transformation model, episode-based payment models, or both types of models. You can also see that a few systems participated in the primary care transformation model only, that's 6%, or one of the episode-based payment models only, that's 3%. The final finding on this slide that I want to mention is that we also found that larger health systems, meaning those with 500 or more physicians, and those that were church-owned were more likely to participate in Medicare APMs when compared to systems without these features. In the last couple of minutes, I'll discuss some of the policy implications from this work. So first, we feel that the results demonstrate the substantial reach of healthcare payment reform in the Medicare program. However, we also believe that in order to fully transform the U.S. health system, many more providers are going to need to engage in Medicare APMs with greater financial risk. Second, physicians and health systems' participation in Medicare APMs is driven largely by participation in ACOs, with relatively few participating in episode-based payment and primary care transformation models. Episode-based payment and primary care transformation models, again, focus on specific types of care or health conditions, but there's still a lot of opportunity for additional physicians to engage, and there's a need to implement more of these models to engage a broader array of physicians. It's also important for future research to examine whether health systems participating in multiple Medicare APM types are implementing those APMs in the same markets, and how those systems are coordinating their participation. Remember, I mentioned that about 20% of systems participating in ACOs are also participating in ACOs and another type of Medicare APM. Finally, to end on a high note, the good news is that participation in these models is likely to increase as CMS is building its portfolio with additional episode-based payment and primary care transformation models, including the radiation oncology model and primary care first. And that is the end of my presentation. I don't know if there are clarifying questions or anything else, but I'm happy to address those.
Thanks, Danielle. I think in the interest of time, I'm going to suggest we pivot over to Jean, since we have a lot of general discussion questions that we were hoping to touch on today.
Sounds good.
Thanks, Jenna, and thank you, Danielle. We've got lots of great questions reflecting the attention and the sophistication of our audience, so thank you for these. Two of the questions, Dave, I'm going to direct to you, and they both have to do with that mysterious database called PECOS, P-E-C-O-S. And the question is, if PECOS required hospitals and physician practices to report the name of their ultimate parent and its tax identification number, how helpful would that be to the task of identifying providers affiliated with systems?
Great, thank you, Gene. That is a terrific question. I think that would be a wonderful addition and a really exciting addition. I'll just go back since you mentioned PECOS. So yeah, PECOS, Provider Enrollment Chain and Ownership System. The way that I think about this is that it's CMS's Medicare Provider Enrollment System to collect that information. And when I talk about it, I'm talking about the data that are collected and available under some circumstances under that system. So yeah, that would be a really exciting addition. It surely would be very useful in identifying systems and their members, hospitals and group practices, and then down to physicians, as we are doing in the compendium. The degree to which I think it would be useful would really depend on how specifically you can define what we mean by systems, ownership, the other key terms that we need to nail down to make sure that we are speaking the same language as those that are providing the information, and then whether those responding and filling out the information understand what we're looking for or what CMS is looking for, and can provide consistent and accurate information over time. But I think absolutely that would be a big help. It would go a long way to achieving what we're trying to do here through the CHSP initiative and the compendium, which is to provide that information on a regular basis using definitions that are nailed down. It's just a matter of, can we get to the people, can we get consistent information and make sure that we all have the same understanding about terminology and what's being collected. I think that would be a big help in studying systems and being able to track them over time.
Dave, and thanks to the questioner. A question to Mike. Some questioners noted that our most recent Compendium of U.S. Health Systems is 2018. Of course, we might anticipate that a variety of things might have changed in 2020. Any insights regarding plans for updates to lists of health systems?
Yes, thanks for the question. It's an important question given the changes in consolidation that are happening since 2018, particularly now. We are optimistic that we will be able to continue to update the compendium. We don't have a particular time frame for that, but stay tuned on our website to look for some more updates.
Mike, questions regarding list. How we're able to deal with who might be linked to multiple health systems. I think that is addressed in two different ways. One in the overall system file, and a separate one in the group practice file.
Gene, just to make sure that I have that right, the question was what we do if we have providers that are linked to more than one system. Okay, I didn't hear a response there, Gene, but I think that was the question. So in the group practice linkage file, a group practice can only be linked to one system. And we didn't get a chance to go into the details of how we link group practices to systems. But I mentioned that we collect a bunch of information and then we make a final determination based on that evidence that we collect, or not, or lack of evidence, to whether a final determination as to whether each group practice and its physicians are linked to a system, and it's either linked to the candidate system or not. So group practices are not linked to more than one system in the group practice linkage file. And then with regard to their providers, we use the MD-Pass data. The MD-Pass data for every NPI that, for a physician that's, or provider more broadly that are billing the Medicare program, there's a primary TIN or group practice, and that's what we use. So in the group practice linkage file, that can't happen. You have physicians that have their primary TIN, and then that TIN is either in a system or it's not. I think what Jean was mentioning earlier in the IQVIA data, that is possible. And so then we use that for analyses, and it really just depends on the analysis and the case at hand. So for example, if we're looking nationally and trying to identify the percentage of advanced practice clinicians, for example, like Rachel's analysis that she presented, we only count them once. So a nurse practitioner could be in 2 systems, but for that analysis, just as an example, they would only be counted once. Another example where they might be counted more than once is that if you have a nurse practitioner that's practicing in 2 different states, and we're looking at state-level consolidation, we might count them twice, once in each of the states. So that's just a couple of examples. That's based on analysis. But in the group practice linkage file, just to reiterate, they can only be in 1 system or 0 systems.
Another question, did a health system have to own and operate a hospital to be included in your definition of a health system? That gets into the whole definition, whole issue. What did it mean in and when we're applying the definition to involve linkages of hospitals in physician groups to systems?
And that's a great question. It comes down to what the data sources use and how they define the linkages in the data. And the way that we define it is that it doesn't have to be ownership. We say ownership or tight management. And of course, that tight management is really just opens us up for, there's some gray area in there, I'll admit. But the data sources have their own definitions that are consistent with ownership or tight management. And then when we combine the data sources, when I say data sources, I mean IQVIA and AHA, and we have to adjudicate because there are some cases they largely agree. There's a lot of concordance there, but when they disagree, we have to decide, and then we do web searches, and we're really looking for things like, well, ownership, number one, would be an obvious tell that yes, it should be in that system, but the tight management, we're looking at a history of a relationship, co-branding, that they list the same physician groups, things like that. So there is a bit of a gray area. It's a great question, but it doesn't have to be ownership, but it has to be what we would call it either ownership or tight management relationship.
There was a question regarding the data sources used to identify the state of scope of practice by state for nurse practitioners and PAs.
Great. Yeah, that's a good question. So we had 2 data sources, one for NPs and one for PAs. So for the NPs, we referred to the American Association of Nurse Practitioners. I think that's actually listed on their website. And then for the PAs, there was a recent article by Valentine et al. That listed scope of practice environment for PAs that we referred to. That's a 2020 article. We can send a link out to that.
A number of questions that relate to connecting the compendium to cost data. And so, Rachel, I thought I would just turn to you for just a moment. I believe in terms of our own work, you did some work tying information on health systems in the compendium to some cost and quality data in a payment model.
Yeah, it's a great question. I think it's certainly an area that we're very interested to do more, and many others have done great work. we've just sort of begun to do some stepping into that space. So we had a fairly recent article analysis that we constructed that looked at how hospitals that were participating in CGR, how their performance under that model varied by whether or not they were in a system. We looked at both the cost and quality metrics that are relevant to the CJR model. So I think that has been our main analysis that we've done under this initiative, looking at cost and quality, but certainly others have done more there. Yeah, go ahead.
Sorry, and apologies to the listeners. I think you're probably detecting we've got some sort of lag in our internet so that we end up talking over each other. So Jenna has been working with Danielle and with AHRQ to summarize how some other folks have been using comparative health system performance resources. So Jenna, I believe you folks have identified some other researchers that have taken the compendium and have linked it to other kinds of performance information.
That's right. And there's been some interesting uses of the compendium, for example, looking at MIPS, I believe.
So, Mike, there have been several questions about related to the pandemic, understandably. I know this is much on AHRQ's mind, and I didn't know if you wanted to sort of bring up what AHRQ's been thinking about relative to the pandemic and thinking about comparative health system performance resources in the community.
Yeah, thanks, Gene. Of course, the pandemic and COVID-19 has affected us all, and particularly healthcare providers. AHRQ recently funded several grants, some new grants, some supplemental grants on COVID-19. Two of our centers of excellence, NBER and Dartmouth, were awarded supplemental grants to study the impact of COVID-19 on the healthcare landscape as well as uptake of biomedical interventions. So AHRQ is keenly interested in more research on COVID-19 and its impacts.
There's a question related to what we can and can't understand about issues of rural health and, for example, access to primary and specialty care using the resources available through the compendium.
So I can start an answer to that. It's another great question. It's something that has been on our minds for a while now. A couple of points. To the extent that, well, we talked earlier about the definition of a system, and we're requiring a certain number of physicians total and also primary care. So one of the things that we've talked about over the past, 5 years, frankly, is what that means for rural areas and rural health systems and how we think of health systems in more rural areas. And frankly, I think that is a limitation whenever we talk about the compendiums and the providers and where they're operating. And then if you have data like claims data that you could link it to, then you just continue to expand the possibilities. But certainly you can look at rural versus other designations and other regions in the country, or any way that you want to slice the data by geography.
There have been other questions regarding linking the compendium to sources of information on outcomes. Didn't know if you or one of my other colleagues wanted to sort of reflect on how one might be able to go about using these various sources and linkage files to connect up with some examples of information on quality of care and outcomes?
I can take a shot at that, and others feel free to chime in. It's a different answer at different levels. Hospital data, there's Hospital Compare, which is publicly available, so you can very easily link the data in the hospital linkage file, which of course links to the system level data. You can link that very easily using CCN to Hospital Compare data, and I would think within a couple of hours you would have a full set of hospital quality indicators at the hospital level that can then be rolled up to the system level. There are a wealth of opportunities also at the group practice level and the physician level. There's just a little bit more work to do there. You can use PAC-ID in the physician compare data and get some outcomes outcomes measures that you could use. Then if you have access to something like claims data or MD Pass, you can take the group practice linkage file and link to those data, and then construct all types of quality metrics, cost and quality metrics. Back at the hospital level, one thing that I think we used for that CJR paper was the Medicare cost reports. That's back up to the hospital level. So those are a couple that come to mind. I think the more access you have to data, particularly when you get down into the finer levels of data like physician data, beneficiary level information, the opportunities and the possibilities just are greatly expanded. Any other thoughts on that from colleagues?
Or Rachel?
Yeah, I think that was a good answer, Dave. There's really endless possibilities for linking here. So, yeah.
We're getting lots of great questions, more than we'll be able to cover in the remaining 5 minutes. So I'll just reassure folks before I move on to what might be our last question. Reassure folks that please send in your questions, and those that we don't get to hear, if we will follow up with you with a response on that question. So if we don't get to your question on the call today, rest assured we will get back to you. There are a number of questions that relate to whether the compendium can be used to understand the access to care for patients that may be at some level of disadvantage, either through disability or other form of social disadvantage. And I'll just briefly mention that Dave pointed to in terms of the list of papers that our team has developed relative to using the compendium resources. We've started doing some work on system presence in individual metropolitan statistical areas. And so, with appropriate data at the local level, one can start to explore the degree to which different systems with different characteristics are making their services more or less accessible to patients who have different characteristics. So there are tremendous opportunities for research to explore those issues, at least in those populations for which data are available. Obviously, one of our problems here is, for example, individuals who are uninsured and they do not have claims that one can identify to connect to our compendium providers. Then you really won't be able to study them. So limitations for studying some populations. Dave or Rachel or Jenna, anything else you want to say at this time on the issue of linking the data sources to access to care for different populations and different communities?
I'll just say, sort of echo what you said, Gene, and second that I think it's an understudied area. I think it is an area that is possible to make some pretty good contributions using the compendium. And just more broadly to the point of linking, the way that I think of these data is kind of a backbone. So it's the structure of health systems at the highest level, identifying the systems, describing them. Then you have the hospitals that are linked and the group practices. And then beyond that, once you can link in the providers to the practices, then it's kind of all possible, right? We go back to what we started with, the motivation that health systems are kind of influencing and touching all aspects of care. You can fill in that backbone, if you will, with all sorts of data once you have those identifiers and the various components of the backbone. And I think looking at disadvantaged populations and rural areas, I think, are really fertile grounds for future work. I think there's a lot to be done there.
And I know we just have 1 minute remaining, so I want to reassure everyone that we are very interested, both our team and AHRQ, in promoting the use of these compendium resources. Feel free to contact any of us with additional questions. Will be available, as you heard from Brian, will be available tomorrow, and of course the slides are posted. Mike, any final word from AHRQ before we conclude the webinar?
Well, I'd like to thank the Mathematica team for all their great work on the compendium and for the presentations and hosting the webinar today. And thank all the participants for your interest in the AHRQ compendium and related research. And we really look forward to hearing from you and seeing research that you might conceive of using the compendium. Thank you very much.
Mike, and thanks, team, and of course to Jenna, our Master of Ceremonies, Dave, Rachel, and Danielle for the great work that they've done and they've presented today. And thank you all for your participation and your attendance. We look forward to hearing from you.